You say Casey's.
There you go.
Oh, there we go.
Alrighty, we have a lot of content to cover today, so I'm going to go ahead and get started.
Okay.
So good afternoon and welcome to our webinar, Diabetes Control for Chronic Kidney Disease Prevention. My name is Casey Stevens and I'm Communication Specialist with Quality Insights. Everyone has entered the webinar on mute, but we will have a discussion following the presentation depending on time. If you have any questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. You can also raise your hand to be unmuted and ask your question aloud. Today we'll be discussing diabetes control for chronic kidney disease prevention. We're going to start with a pre-knowledge check so we can further evaluate what was learned here today. So if you will take the time to scan the QR code on the screen, I'll also drop that link in the chat so you can answer those couple questions. I think there's only 8 and a lot of them are simple. Just go ahead and start filling those out to the best of your ability before we get started today. I'm going to go ahead and drop that in the chat as well. Alrighty. And so this webinar is also eligible for continuing education credits today for nursing as well as dietitian continuing professional education credits. You can see the details about those credits here. If you're interested in obtaining credit, you'll need to stay for the entire webinar that is 60 minutes and complete an evaluation and knowledge check. We'll share the link to the evaluation at the end of today's discussion. And now I'd like to introduce our presenter today, renal dietitian nutritionist Jillian Pate. As a renal dietitian, Jillian has worked in the kidney world for over 7 years. During this time, she realized the importance of preventative nutrition education for those with CKD. Her vision for clients is to gain a better understanding of their own personal walk with CKD and how she can provide the appropriate recommendations and resources to help them feel educated, encouraged, and empowered. Alrighty, and without further ado, I'll let Jillian take control from here.
All right. Good afternoon, everyone. I'm going to get control over it real quick, and then we will get started. Thank you, Casey, for my introduction. I'm going to kind of slide over that slide. And it would help if it was like actually wanting to let me control it. Okay, so while I'm getting it rolling, just as kind of another overview, I have been fortunate to be in the kidney world for the last 7 to almost 8 years. It was something that I didn't have a lot of education on in college, in my undergrad and graduate school. And I just really fell in love with just kind of the subsect of renal because you don't get a lot of just really more detail with it. Should be good. Casey, it says I have control, but then it's, okay, here we go. Here we go. I apologize. I kept saying I had control and then it wasn't doing much. Okay. All right. So a part of my presentation, these are some of the objectives that I am going to review, really so that way you guys could walk away. I know you guys just took your pre-test, but these are some things that I want you guys to walk away with today. Of course, understanding the mechanism of, really how blood glucose control can prevent CKD progression, really identifying the role that as a dietitian that we play in medical nutrition therapy, to halt CKD progression, but then also really kind of go further to explain really the difference between a registered dietitian and a renal dietitian and how we can start implementing kidney nutrition. Okay, so a little bit about, with the kidneys, obviously we know the importance of our kidneys, but I always think it's a nice little refresher just to kind of heads up, because I'm going to talk about some of these issues as I talk about the nutrition side of it. So, of course, with our kidneys, they are thankfully in charge of removing waste product, removing excess fluids. However, they also critically regulate our sodium, potassium, and protein levels. And so a lot of times with chronic kidney disease, what we're going to see is the most prevalent cases of that is going to be if maybe you've already had another chronic disease state, such as diabetes, maybe you have hypertension, polycystic kidney disease, as well as kidney stones. So I wanted to put this in there. Many of you guys might have heard, the National Kidney Foundation, they do a great job of really putting the awareness out there about 37. 37 is kind of their challenge. They use a lot as far as like walking 37 miles through a month, really bringing awareness out. And the reason behind that is because we have right now 37 million Americans with chronic kidney disease. And the leading cause of chronic kidney disease is diabetes. So I was really grateful for this opportunity today to talk a little bit more about how us having more control over diabetes and how that can halt further progression with chronic kidney disease. You can see right there, it says 40% of individuals with diabetes end up having CKD. And just to throw out there, I'm not going to really touch much on hospitalizations or really the costs so much, but I did want to put that out there. This was something in my previous research, but an average hospitalization for someone with CKD is around $18,000 per hospitalization. So just like anything, us getting out there and providing more prevention, that's where not only are we going to halt the progression, but we're also going to help out with reducing the rising rates of healthcare. So how does blood glucose affect your kidney function? If we're in the healthcare system, one of the very first things that I learned is even though there might be so many things that are in critical condition, as a dietitian, one of the very first things we look at is what their blood sugar looks like, because that can affect so many things. With hyperglycemia, really the way it has an impact on our kidneys is that it goes right after the vascular system. The higher our blood sugar stays, and especially in a continuous state, it's going to really wear and tear down our vascular system and the nephrons in our kidneys, which of course are filtering, our blood, our fluid once again, and, really attacking all the things that our kidneys are known to take care of. It also is, it's forcing the kidneys to work harder due to the increased blood flow. So one of the ways that by us controlling blood sugar is that we're able to get that more into a stabilized state. It's going to help lessen the workload of our kidneys, which overall is going to help reduce the rate of them actually getting chronic kidney disease. So looking at, the difference really between type 1 and type 2 diabetes, with type 1 diabetes, we often, recommend within the first 10 to 15 years after onset of type 1 diabetes, that is sometimes when you're going to see CKD present itself. It's a little different though with type 2, mainly because a lot of times, individuals can have type 2 diabetes for a number of years before actually getting diagnosed. It's more common, of course, with type 1 to be diagnosed based on symptoms and have that taken care of a little bit more quickly and promptly. So typically, your medical care team is going to be a little bit more hands on deck with your kidney health. But with type 2, a lot of times you're almost going to have CKD by the time your type 2 diabetes presents itself due to the delay in diagnosing. Something I wanted to mention that was on that last slide, but I went ahead and just wanted to touch it now is, protein in the urine. So a lot of times when we see that protein present in our urinalysis, that commonly indicates kidney disease. So not only are we looking at some of the other markers such as creatinine and their GFR and just different functions of their kidneys, but we're also looking in the urinalysis to see how much protein spillage is actually in their urine. So I wanted to quickly kind of identify some of the symptoms that we would see with someone with chronic kidney disease. And as you can kind of read over these, they actually kind of cover a numerous amount of diagnoses. So you look at, less energy, trouble concentrating, urinating more often than normal. Some of those symptoms, of course, they mimic diabetes in general. So if you already have diabetes, you might not always think that it's related to your kidneys, just more of your diabetes state. If your feet and ankles are staying swollen, that, of course, can also mimic if you have a history of hypertension and you're already dealing with fluid balance. So you wouldn't always necessarily think that that's your kidneys. However, when you do start seeing your urine becoming more foamy, or you might have blood in your urine, that is something that kind of triggers for kidney disease, as well as poor appetite. So part of the diagnosing process of CKD, and this is one that I like to discuss, is because if we are only seeing patients or individuals, in either, an emergent standing at the hospitals, or if we're getting a little bit of blood work here and there, it's really hard to identify what's going on, right, with any kind of disease state. A lot of times we're looking at the routine lab work for over like a 3-month stance. If we're starting to see their kidney numbers being elevated, we're not just going to automatically look at that and think, okay, they have chronic kidney disease. We're going to take it a little bit further, get a couple more trends to go off of before truly diagnosing them with CKD. We look, of course, at their lifestyle here in the Appalachia area. Unfortunately, it's a little bit more common to have a sedentary lifestyle, which in turn tends to be more in our obese population that we run into that. Genetics do play a marker in CKD, especially if you have polycystic kidney disease. It's a little bit different. Polycystic kidney disease and CKD, we do take care of them a little differently, but at the end of the day, we are looking at the decline of their kidneys. And then if they have another chronic kidney disease state or another chronic disease state, such as diabetes, if you have a great care team, they're often going to jump on and start marking their kidney numbers, as well as checking with their A1C. Okay. So I wanted to kind of go over, if you're not familiar with, but there are 5 stages of kidney disease. Oftentimes the first stage, you almost don't even know you have it, of course, because your GFR is pretty much remaining above 90. This is pretty common when you're in the hospital. You might have an acute kidney injury. Stage 2, that's often when you're going to start seeing a little bit of a decline. You can see the GFR is between 60 and 89. Typically minimal side effects. This is ideally when we want to catch it, but that's not always the case. Stage 3 is typically the most common of individuals that I work with, mainly because this is when some of their symptoms are arise. A lot of times if they're hospitalized, honestly, to a different diagnosis, then that's when some lab work will come out and they'll realize that they're already stage 3 chronic kidney disease. Stage 4, you're going to start seeing a drastic kind of decline, poor appetite, very low energy. Like I said, some of these side effects are challenging because if we already have someone that's dealing with other disease states, it's hard for them to really pinpoint that it might be their kidneys. And then, of course, stage 5 is when they get critical. If they're following a kidney doctor regularly, that's when they'll pretty much be recommended to start dialysis. However, some that might have been diagnosed with stage 3 CKD, about 10 years ago, and unfortunately stayed kind of non-compliant with any kind of interventions, they might end up going to the hospital due to feeling so poor due to the toxins building up in their body, and then at that time be started on dialysis in the hospital. So the reason I wanted to kind of stack this out is because between stage 3 and stage 4, we really have that opportunity to halt further progression, especially with nutrition, but also making sure that we're identifying, if these are our diabetic patients, what we can do to continue to halt further decline. And one of the things I specifically target when I first talk to my patients is, okay, are you diabetic? If they respond yes, we identify, okay, what has your blood sugar been running? What's your A1C? I can say hands down, I have a majority of my patients that do not check regularly. And so that's kind of where we start. We start with, okay, let's start checking it. Let's make sure you have the supplies that you need. And then we're going to be able to build off of that to get better control. Okay, so as a dietitian, what I provide is called medical nutrition therapy. And part of that is I am assessing, I'm assessing their symptoms. I'm really kind of assessing the whole situation, because when I do things, I look at everything at a very individualized approach, which is one of the reasons I love what I do, is because it's a pretty big stigma with dietitians that we pretty much take things away from, the patients that we're working with. We take away everything that they're enjoying. We kind of we put off all the things that really help them enjoy their life. And that's just not true. What we're doing is we're coming in and we're trying to kind of assess the whole situation, meet them where they're at. Here in the Appalachian area, I always like to address that there are plenty of options. We just have to get the right resources in their hands. So we assess symptoms, we review lab work, we of course monitor their blood glucose labs, as well as we encourage them to get their A1C checked twice a year, at least at the minimum. Then we kind of dive right in as far as looking more at their sodium, their protein, potassium, and I'm going to talk a little bit about that in just a moment. So oftentimes you'll find us as dietitians in a couple different settings. In the hospital setting, a lot of times we can get referred while they're in-house when they're in acute. The hardest part about this, though, is typically when we have a patient that's in the hospital setting, they're normally in there due to some sort of element that has helped them enough to make them stay in an acute setting, which means this is not the ideal time for a dietitian really to be able to provide all of the expertise we have to give. The best case scenario is if they have a great support system at chairside that we can kind of start going over some different support systems as far as controlling their blood sugar, as well as, really kind of reviewing any of the most pertinent labs that we have right there in front of us. But ideally, outpatient setting is where we're going to get most of our impact, working one-on-one with our patients. So there, of course, with anything, any kind of intervention, working with providers, there's always going to be some barriers. So I wanted to take the next couple of slides to go over some things that I personally have dealt with some of my patients that I work with. So this is a very common statement, but it says, my doctor doesn't think a nutrition consult is needed at this time. I do think a lot of times physicians or other providers, nowadays we are so quick to have to get through what we need to get through, to add another subsect, to add another topic to their conversation, to make it go out further. It almost just seems like I can take care of this. Let's just do these very minimal steps and you'll be fine. But what I've ran into, though, is the patients that I do start working with, and oftentimes it's after they've sought me out instead of the doctor referring, is they're completely overwhelmed with how much they have to change in their diet, that it's almost kind of baffling that we don't address it sooner. And so that's what kind of goes into this next one, is I was so concerned what I could and could not eat with diabetes. So I just stopped eating. And this is the same thing. So I've heard the same verbiage with diabetes, with CKD, whenever you get a new medical diagnosis. And I'm sure I can relate to many of you, is, whenever we hear something, our first reaction, our first response is that we often want to go online. We want to research, we want to figure out what's going on. I will say this, it helps when you're an educated medical professional, because you can kind of essentially filter through a lot of the verbiage. You can filter through recognizing things that are just appropriate and things that are just so off canter. But with our patients and the people we're working with, if they start Googling and doing their own research, they're going to get to a point that they are so overwhelmed that they are going to stop eating, or they're going to limit themselves so much that it doesn't even pertain to them. Because once again, everything that we work on from a nutrition standpoint, it has to be individualized, especially with their lab work. Just because you have chronic kidney disease does not mean that you have to stay away from all the other foods that someone else with chronic kidney disease would have. So I'm sure that you might have heard this before. Diabetes has taken everything I love to eat away from me. A lot of times we have that stigma with diabetes as far as having to reduce our carbohydrates, having to take away all of our sweets, especially, this time of the year, we're in the holiday season. And it gets very overwhelming, because if they have really been on target with their blood sugar, they are really nervous. They're very scared about things to limit. They're nervous about things that they normally would have with their family members around this time of the year. So instead of actually understanding the importance of moderation and portion and what we're really looking at, And it's easy when we work in this and we see the benefit of, hey, if you're going to have, pumpkin pie with your Thanksgiving dinner, just eat it a little bit closer to your mealtime so that way your body doesn't shoot your blood sugar straight up. It's small little interventions like that that really can help them enjoy the time that they are, with family, and just to really walk out their life with their chronic disease diagnosis. So some of the barriers I most commonly seen is that there really isn't enough dietitian support. Patients are not being referred to our services, as well as we're looking at cost of services. Once again, we're looking at another provider, but at the same time, if we're looking at, referring to another provider, sometimes the patients are going to look at, this is just another expense. This is just another bill, and I can't do that. Transportation is also a barrier. But what I always like to do, and it's just my personality, is I always like to spin it. I always like to stay optimistic with how we can make the situation better. I know the importance of building rapport with providers. I know the importance of us creating a better referral-based system, as well as how important it is for us to get credentialized as dietitians in the insurance field. So that way we can actually build insurance companies and really reduce that burden of our patients having to pay out of pocket. Where I live, telehealth is huge. I will say that is something that, unfortunately came out of the pandemic, but it has really benefited our healthcare system by being able to provide telehealth services more regularly. And that's actually where I see the majority of my patients now. So how can a dietitian benefit your interdisciplinary team? So what we're here for today, of course, is talking about blood glucose control. We are another person to be on the team to really help support that blood glucose control. And the way we do it is not just giving them a meal plan, but really sitting down, walking them through, educating them on what we're looking at. I don't feel like it's as beneficial to just have this handout in a doctor's office just to hand to them and say, these are the things that you should stay away from, or these are the things, this is the meal plan, follow it exactly, because it's going to look so different. And why not take a little extra time to recognize, like, hey, he doesn't like asparagus, he doesn't like drinking milk, he doesn't, like a lot of things, this meal plan is not going to work. Well, guess what? We can sit down and we can really kind of work through what this person likes and doesn't like to make sure that they are staying nourished, make sure that they're enjoying what they're eating, and at the same time getting control of their blood glucose level. With that, we're helping to reduce hospitalizations, because one thing that I've noticed is if we're not addressing their hyperglycemia, if we're not addressing, their blood glucose, that could honestly, the longer it goes on, can then stem down to CKD. Also, it can go into other cardiovascular issues. So by us doing that, we're helping to reduce hospitalizations. By taking that little bit of extra time, we're also having the opportunity to address any kind of food insecurities. So if I'm talking with someone and they're pretty much being transparent with me and saying, you know what, I can't afford some of these foods. I don't even know what some of these foods are. It's our job that we can actually take a step back, work with social workers in the area, work with the food bank, work with other resources that are available to help them get some of these nourishments into their home. And that is something that we've been working with the Facing Hunger Food Bank, is they actually have a food as medicine program. And I love that because we're not only providing these individuals with food, but we're actually giving them food that's going to benefit their chronic disease state. And then something I like to touch on is that we also help improve their medication adherence. And really the way we tie into that is because you got to think, if I have a patient that I'm working with, say they're not eating like they should be, their blood sugar is all over the place, say that they just really limited their intake, they're not drinking as much. A lot of times if they keep taking their medication as prescribed, it could cause a lot of GI distress, which then in turn would actually make them want to stop taking their medication. Also, if they've reduced their intake, they also might have reduced their body weight. So blood pressure medication, different things like that, even their medication they're on for their diabetes might not be appropriate due to the weight loss. So there's a lot of benefits by us coming in and helping them feel more confident with their intake. So that way, when they're continuing with their medications, they're going to continue to feel the best they can. So, did you know there is actually 111,000 registered dietitians here in the United States? Out of that, there is actually 570 that are renal dietitians. And here in West Virginia, we have two renal dietitians, myself and my friend that has worked with the transplant center up at CAMC. And I'm excited for her because she is continuing to move on to more endeavors with CAMC, but she is our other renal dietitian here in West Virginia. So, as a dietitian, I get asked pretty often, what's the difference between a dietitian and a renal dietitian? And it's just like any other professional in the healthcare system. Whenever we can take a little bit of time, do a little bit more research, and kind of make that our specialty, that's where I feel like we can provide the best support. I'm still a dietitian through and through. So I have several dietitians that reach out to me asking me questions about kidney nutrition. I love it because I'm able to share my expertise with them on things that we would normally look at. So what we do though is we just take a closer look, and where we see kidney patients on a more consistent basis, it really opens up the opportunity for us to see other areas of where nutrition can play a big part. So once again, we're continuing to individualize the goals, based on their current diagnoses, on their lab results. We're of course addressing their blood glucose control, but something that I mentioned earlier is we also review foods high in potassium, phosphorus, and sodium. The fluid sodium balance in their body, that is something that we talk about on a continuous basis, because once again, I don't want to just hand out information that's just giving them just the simple basics of stay away from this and stay away from that. But I really want them to understand, like, hey, if you reduce your sodium intake, or if you would choose this product over that product, you're going to start seeing some swelling going down. And that is hands down when I'm working with someone with swelling issues. One of the best things ever is when they message me and tell me that they can get their shoes on for that week. So really meeting them where they're at, helping them have those nutritional interventions in place so that way they can just feel confident. I think that's where it's at. We got to be confident with what we're recommending to our patients, because of course that in turn is going to help them stay confident. So protein is something that we talk about often. With blood glucose control, this is huge. Okay, so as a diabetic, if I'm just looking at someone that has diabetes, I am always talking about the consistency of protein. Protein, is what's going to help halt that blood sugar to really kind of spike up. It's going to help you have more of that gradual, just steady blood glucose level after your meal times. With protein, it's going to help promote wound healing. In the diabetic setting, we want to make sure that any of these diabetic ulcers, anything that's coming about where we know that having a higher blood sugar is really against that wound healing, we always want to make sure we're incorporating enough protein with that. So this is something that we always talk about and encourage on a consistent basis. But what happens is when you actually have chronic kidney disease, we have to kind of scale back on how much protein we're having a day. This can be really challenging because if you're a diabetic and you find out and you're really trying to get blood glucose control and you really start pushing that protein very hard with each meal, but you might not know that you have chronic kidney disease, what you really could be doing in turn is actually harming your kidneys more. Your blood sugar might be seeing a little bit of improvement there, but you're also making your kidneys have to work a lot harder. So in turn, we're not really always getting the best benefit. So that's where, as a dietitian, we come in. You can see some of the medical nutrition therapy parameters I have there on the screen. I look at really what stage of chronic kidney disease they're at. I assess if they have diabetes, because once again, like I said, that does kind of determine how much protein I'm going to be recommending. And at the end of the day, our body, what it does is it takes that protein, it breaks it down into waste in our body. So by us kind of pulling back on how much protein we're doing, it's making our kidneys work a little bit less and not be so strained all the time. Real quick, I didn't put this in my slide, but I just, think it's something good to bring up is a lot of times when we hear the diagnosis of CKD and pulling back on protein, it's very quick to want to pull back and do more of a vegetarian lifestyle, pull away from all animal-based products. And really what I can say to that is, depending on your patient, if they truly rely on animal-based protein for every single meal throughout the week, that's what they live on, I wouldn't go to a complete extreme. I mean, recognize the area, recognize the clientele you're working with. Is it really feasible? And start scaling back. Absolutely. I have seen vegetarian lifestyles work tremendously because vegetarian or plant-based protein essentially isn't going to be as harsh on your kidneys as, it doesn't have much of a waste product like, animal products do. But I just want to say it's not one of those things that has to be one extreme or the other. I think it's essentially just starting to pull back some and really explaining that to who we're working with so that way they feel more comfortable with why they are, why they're stubbing out their steak for a little bit more of like a bean dish, things like that. So potassium. Potassium is something that we look at. This is something that is promoting our heart to squeeze up blood through the body. It helps promote muscle movement, and also it filters blood through the kidney. A lot of times with potassium, it's so important for our heart, but a lot of times we don't recognize the relationship that our kidneys and our heart have hand in hand with this potassium. There is a guide that I do use for this that has like higher and lower potassium foods. I have some people that have CKD, and honestly, the way their body is responding to this disease state, it sometimes can be really quickly that their kidneys are no longer filtering out that potassium. But then there's some that their body is still having some of that filtration going, and potassium isn't much of an issue. What I run into is someone that finds out they have chronic kidney disease and completely avoids potatoes and bananas and orange juice and tomatoes and all the things they love that are high in potassium. And honestly, they might start out and they actually have a lower potassium, and they could get themselves in trouble for reducing their potassium so significantly. So that's why we really have to encourage them not to always rely on their research, because once again, if they're filtering through at their own discretion, they might not realize the importance of still keeping a moderate potassium intake diet. And that's really where a lot of my patients stay. I have some, of course, that are on low potassium diets, but more so than none, they stay on a moderate potassium diet. Phosphorus. So phosphorus is something I wanted to address because unless you're familiar with the kidney world, you don't often hear of phosphorus. So phosphorus along with calcium, they work hand in hand to work up our bone health. So once again, our kidneys not only help us get rid of the waste and the fluid, but they are really in charge of our bone health as well. Phosphorus is something that is normally able to be filtered through our kidneys on a regular basis. However, if we are not having that filtration like our kidneys normally provide for us, then at times that phosphorus is not going to be removed from our body. And what it's going to do is it's just going to stay in our system, and it's going to essentially add like another toxin in our body. It's going to really be harsh on our vascular system. It's going to help trying to keep getting that calcium. It's going to kind of resist that calcium a little bit and make our bones feel more brittle and weak. So one of the best things that we can do to help reduce that phosphorus level is, of course, address it with diet. It's honestly most commonly found in more processed foods, dark colas, lunch meats, dairy products, things like that. Honestly, things that a lot of my patients heavily rely on. So we start just kind of really start sliding back on that a little bit, really watch a portion. If we're drinking, 6 Pepsis a day, can we move back to, 3? We start where we're at and just kind of work there just to help, see those numbers start coming down. There is also a medication called a phosphate binder. Not many of my CKD patients are on phosphate binders. They're more so on it when they get on dialysis, but that is another way to get that removed from their body. Okay, so I wanted to show you guys as a provider what a referral model kind of looks like right now. So this is kind of spinning down from like a hospital setting. Okay. So as you can see, when we are ready to discharge a patient from the hospital, we are making sure that we are having a lot of check marks off. We're looking at making sure they have a follow-up appointment with their PCP, any pertinent medications being called into their pharmacy. If home health consults are applicable, we're doing that. We're getting medical supplies ordered. And then I had to throw this one in there about the survey call because I feel like that is a very consistent thing after they leave the hospitals to get those survey calls. So, but with that, you can kind of see that's like our frontline defense. We see someone, we take care of these things, and then at that time, just looking over there at the PC follow-up appointment, It then at that point steps down and you can see it refers to other disciplines based on like why that patient was hospitalized. So for example, if we have a patient that has uncontrolled diabetes, goes into the hospital with hypercalcemia or glycemia, or they're in the hospital, like they're end up being DKA, things like that. They get them stable, they're ready to discharge. They make sure to take care of all these situations, especially if that patient may have been out of medications and that's what caused some of these issues. And that's kind of where we take care of it. We almost essentially kind of put a band-aid on that situation. But something that, in a very biased standpoint, I'm going to honestly put that out there, is this is where medical nutrition therapy can really make more of a difference. Okay. So I've just spent the last several moments talking to you guys about, what CKD kind of looks like, what dietitians can do. But here's the thing, at the end of the day, we have to get ourselves in there as been seen as a provider. So that way we can, when this patient is getting discharged with high blood sugars, maybe they honestly have found out that they now have chronic kidney disease due to their diabetes. We want to be right there with our medical nutrition therapy, able to help right there. Now, I'm not naive. I recognize that there are some patients that are not really going to want our services. Like I said, there is a very big stigma there that we're essentially going to take away everything that they enjoy eating, that we're going to make things not really applicable for them, for their finances, for where they're at. They honestly might be really overwhelmed. If they are in the hospital, they're not feeling their best, we're going to realize that, this might not always be the best opportunity to catch them. But from a dietitian standpoint, even if we can get their information referred to us as dietitians and even reach out to them a week or so later to get that set up, that's really helping us set the opportunity for us to get in there. Because with doing this, you can see up here on the front line, we're getting straight in versus down there, many steps down the road, we might eventually get in touch with some of these patients. Well, it's not going. Okay. Thank you. Okay. Cost of services. So once again, there are a lot of medical nutrition therapy coverage now through insurance companies. Thankfully, Medicare has really kind of set the lead on that. So as a dietitian, we can provide up to 4 visits a year. However, if you're diabetic or you have CKD or other chronic disease states, all we have to do is reach out to the referring provider and get almost like another need for seeing the dietitian. And then at that point, they actually get unlimited coverage, which is free to our patients. Now, if they have like a secondary, things like that, and I'm not going to go too much into that, but there's other ways that we can provide our services to that way. They're not as, I think the most I've had a patient have to pay out of pocket is, a very small amount. But typically what we like to do is we like to be able to provide this through insurance. That way they can get the best help. Paying out of pocket, it's not always feasible. I don't ever want our medical nutrition therapy services to be a barrier due to finances. So we try to make that as accessible as possible. So I pulled out this statement because I felt like it was just really pertinent for kind of what we talked about today. But it says structured education is critical to engage people with diabetes and CKD to self-manage their chronic disease state. I know that's a lot of verbiage, but essentially what I loved is that it says we want to promote more diabetes self-management programs. This is where it's at. Not only do we want to be there to educate and support, we want to show them step by step, making them feel more comfortable in the process. There has been so many great resources through the year, and I don't ever want to discredit the professionals before me that have really, led the way. They have made so many things easier for us as providers now to get to these patients and to have the information we need to help provide them the nutrition education. But where we're at now is we are seeing such a rise in chronic kidney disease that we have to come to a point that if diabetes is the biggest target area of chronic disease state, what we do is we have to scale back and we have to recognize that those with diabetes, those with that diagnosis, we got to get them in for more preventative screenings, getting them to feel more accountable and take initiative. And like I said, I'm not naive. I've worked in the healthcare setting for a really long time, and we can say all these things and we can have all of these agendas and initiatives for things. And at the end of the day, we can't make them do anything that they don't want to do. But as far as I'm concerned, we can still be there to kind of stand in the gap for them. We can be there to be able to provide these resources, hear them out, make them feel like they're not alone, give them the support they need, and really, as providers, lean on one another to recognize that it's not just a one person show, that we need one another to be able to have that accountability, to be able to have the referrals, to be able to have that support system really in our professional world. So that way we can then pour it out into the people that we're working with. So this is something that I kind of currently work on, and I just kind of wanted to show you what a flow would look like working with a dietitian. Is once we get a referral, we essentially work with it. We take these patients that we're working with. With my practice, what we do is whenever I get a referral from a doctor, I look at them, I get assigned, to them. We make sure that they are getting scheduled in a timely manner, because I know that if we wait too long after referral, it's so much harder to capture these patients. We want to make sure that they are being contacted. We want to make sure that they know really what we provide, know that the services are covered, pretty much try to really identify any barriers early on, so that way we can set up the most successful program for these patients. Once again, collaboration's huge. I make sure to collaborate with their physician, whoever is their referring nurses, anything like that we can talk to really make sure all hands are on deck. I initiated a program that helps really us just focus on what we're looking at. A lot of times it might start slow, because once again, if their blood sugar is not controlled, we always start there, because I know hands down, if they are already CKD stage 3 or stage 4, they're getting worrisome. They're pretty much grasping at straw saying, hey, what can I do to stop this kidney disease? When I tell them, hey, do you have diabetes? And they say yes. And I say, okay, what's your blood sugar running? Oh, I'm not sure. What was your last A1C? Maybe 8. I don't know. It's been a while. Okay. Then I'm like, okay, well then let's focus on getting your blood sugar taken care of. Let's look at that. A lot of times you're like, well, I mean, I'm taking metformin, I'm taking this, I'm taking that. And it's like, that's great. But we have to take a step back, and we have to recognize, until we can get their blood sugar in control, we're truly not going to be able to make that much of an impact with their chronic kidney disease, until we get that blood sugar controlled, get that vascular system to be a little bit more supportive, so it's not so much wear and tear. I mean, it is truly that simple, that if we can just get more of their attention on what we need to look at, we're going to be able to halt further progression. And that's essentially with where we're at. We don't want to see more patients going on dialysis. Dialysis is booming, and the CKD rates are rising. And, diabetes has been such a hot topic for so long. And at the end of the day, it's just going to continue to take, the providers and renal dietitians and dietitians stepping in and really being seen as, as a provider, just like everyone else. All right. And that is a very winded conversation, but I really do want to just say thank you for giving me the opportunity to just really kind of give you a little bit more insight to what it looks like being a renal dietitian, and what we can do to help support, CKD prevention.
Thank you so much, Jillian. We really appreciate you joining us today. I'll let anyone who has a question kind of start to filter those into the chat or the Q&A. And while we're waiting on those, I'd like to run over a few closing items. First, I'd like to remind everyone wanting CEs and CPEs for today's webinar to stick around to the end so we can direct you to the post-webinar evaluation. So we're going to advance the next couple slides here. So here is a link to the evaluation and post-knowledge check. I'll also drop a link to that in the chat, so that way you can have it, but you can also scan the QR code on your screen as well. In order to receive your free nursing CEs or dietitian CPEs and certificate of completion, you will need to complete the evaluation and post-knowledge check. Once you have successfully completed both, you will be forwarded your certificate. As you can see here, we've got a couple ways for you to do that. Or you can wait until I end the webinar. You'll see a pop-up window from Zoom and asking if you'd like a link to the evaluation. And then if you have any questions about CEs, CPEs, or the certificate you received at the end of the evaluation, you can email Andrea Lefke at lefke@qualityinsights.org. Or if you have other questions, you can contact me at kstevens@qualityinsights.org. Alrighty, so Jillian, it looks like we've got a couple questions here in the chat. One is, how do we get a copy of the recording? And that will be emailed to you later this week, and also be available on our website in case someone you know really missed this helpful information today. We'll have that available. And someone else just said thank you for the information. So I'm going to go ahead and drop that link to the chat in the, or link to the evaluation in the chat. Jillian, it looks like we do have a question today. Do you have any recommendations on a broader comprehensive kidney education program where patients have transitioned to stage 4 or 5 and heading towards dialysis?
Yes. So that is something that, I provide in my services. So that's something that if they're interested, can provide me information for them just to kind of help you get some further education there. It depends on like where your patients are at, but that's, I'm licensed in Ohio, Kentucky, West Virginia, any opportunity that I can to help. If not, I can always help you with other dietitians to meet with. I will say we do have with Quality Insights with our renal network, we do have our kind of our kidney care advocates who work sometimes with like our stage 4, stage 5 individuals preparing for dialysis. They are great help. So a lot of times I'll even tag team with them a little bit. If I have someone that's stage 4, stage 5, they're learning a little bit more about dialysis, but they're not at that point yet. I kind of step in and give my expertise and nutritional help there, so that way we can hopefully maybe halt that progression for a little while longer.
Fantastic. Thank you so much, Jillian. And if anyone else has any other questions, feel free to reach out. But thank you so much for joining us today. And if you have a few moments after the webinar, feel free to fill out that evaluation as well. Thank you all so much and hope you have a great rest of your week.
Thank you.